My name is Thara Vijay, and for those of you who don't know me, I'm the medical director of our care clinic, and it's really my sincere pleasure to introduce Dr. Ellen Eaton, who is an associate professor of medicine at the University of Alabama in Birmingham. She's a native of Dothan, Alabama, where she completed her internal medicine residency and chief residency after which she completed her internal medicine residency and chief residency at Stanford in 2011 before returning to UAB to do her fellowship and subsequently joined as faculty. Her research and patient care centers on infectious consequences of substance use and mental illness. Her lab is developing and testing interventions to link patients to addiction and infection prevention and treatment in both acute care and community-based settings. Dr. Eaton uses implementation methodology to identify treatment gaps and healthcare delivery innovations in rural and poor regions in the Deep South, which she has capitalized, the Deep South. Dr. Eaton is also the director of the office-based addiction treatment clinic at the 1917 HIV clinic and director of the UAB Center for AIDS Research, Substance Use, and HIV Working Group. She's a National Academy of Medicine emerging leader and serves on the SUD Opioid Collaborative Working Group and the Learning Health System Subgroup. And in 2024, she was named to the IDSA HIV-MA Board of Directors. In addition to her patient care and research, she has held public health roles within the Jefferson County Department of Public Health and the City of Birmingham COVID Incident Command Centers. And with that, welcome, Dr. Eaton. It's such a pleasure to have you here. Thank you for joining us.
Thank you so much for that introduction. Can y'all hear me okay? I usually project pretty well. Okay. And I'm going to just put my cold beverage right here. We're going to be talking about integrating services today to end the other epidemic. And I know a lot of us work on HIV, and you'll notice a lot of parallels between the substance use crisis that we're experiencing and what a lot of us have worked to end towards ending HIV, many of us over most of our careers. So my disclosures. All right, so for objectives today, we're going to start by talking about missed opportunities for substance use screening and treatment. I'm going to share some models of community-based care. And then lastly, I'll also highlight some opportunities for integrating care for acutely ill, for example, hospitalized patients who use drugs and inject drugs, which is a big touch point in many rural areas. My personal objective is that I can change the way you view how people in your community who use drugs and change the way you view your role specifically in the health and research equity for this population, which has been excluded traditionally from a lot of our clinical care and research initiatives. Okay, we're going to start with a Taylor Swift slide. This is for Dr. Landovitz. It is relevant. So in thinking about the Eras Tour and many of these large concerts, you may or may not appreciate that the number of attendees is actually on par with the number of people who die of overdose annually. So for example, in comparing Arrowhead Stadium, had about the capacity of our overdose fatality rate in 2023, which was 112,000. So when you think about that number, that's truly how big the overdose crisis has been in the US. And that's just the tip of the iceberg. And I'm going to share the other consequences that have gotten less press, specifically infectious diseases and HIV. Many of you may not appreciate that we have an active opioid public health emergency. This has been renewed since 2017. And we are seeing some improvements in this public health emergency, but the consequences and health outcome have still merited a continued emergency here in the US. And I do want to comment, specifically, this is named around opioids, but there are other substances that are causing a lot of adverse health consequences, stimulants, benzodiazepines, and then non-opioid sedatives. There's a lot of designer drugs that we're hearing about that are causing health consequences, including HIV transmission risk. And then also, as I mentioned, a lot of infectious consequences that come with substance use, HIV, Hep C, endocarditis, but also things like STIs, strokes, heart attacks. So a lot of public health burden in these populations. This is a slide I got from my colleagues who were at the Equal Justice Initiative starting a reentry clinic. And they reminded me that a lot of the public health burden across the US can be traced to systematic barriers to care, systemic racism, oppression, lack of Medicaid expansion. This is a map from 1860, but you can see there's a lot of similarities here in the Deep South with the slave states from the 1860s, and areas which have chosen not to expand Medicaid, for example. My state, Alabama, still does not have Medicaid expansion. Here you can see heart disease death rates. Again, same geographic distribution. This is cancer deaths. Again, same geographic distribution. Amputation rates, so chronic diseases, limb-threatening conditions, and then more recently, COVID deaths. This map cuts off California, but I do want to appreciate that there are many rural and poor areas in many states, including West Coast states, that also have a lot of chronic disease, including HIV. And so I call these sociopolitical determinants of health, and I know many of you have heard that term as well. Narrowing it down to how these determinants affect substance use, I want to show you the opioid dispensing rate. This is CDC data from 2024. And you can see that the Deep South, some of these same areas have the highest opioid dispensing rate. So these are prescriptions by providers for chronic pain, for example. But then when it comes to use disorder, so if someone were to develop opioid dependency and a use disorder and needs help for their use disorder, you can see that many states have limited treatment access. So in red, you're seeing states where the percent of Medicaid enrollees with opioid use disorder who are receiving medication treatment is about 0% in these red areas. My state, Alabama, doesn't even report their data, but I can assure you it's not great. Or else you wouldn't have an ID doctor talking to you about substance use disorder, right? Filling these clinical care gaps. And then when you think about percent change in overdose deaths, some states are really seeing improvements, and that is great news. Nationally, we're seeing a decline in overdose deaths, but you're seeing some states, Texas, Alabama, up the southeast, a little bit mid-Atlantic region, these areas in orange and red that are not seeing the decrease in overdose deaths that the rest of the nation is experiencing. So still a lot of work to do. And again, this is just one outcome. This is overdose. But we have a lot of other public health threats associated that we call syndemics. So this term syndemic may be new to you. It is a term that was first coined decades ago to describe the synergy of two or more diseases and the social context in which they occur. So it was actually first used to describe HIV, substance use, intimate partner violence, and adverse mental health, and how these are mutually reinforcing interactions in our patient populations. Specifically, substance use, violence, HIV, and AIDS and Behavior article from 2013 that when I reviewed sounded very similar to what I'm seeing now in 2024. And you may have noticed that injections specifically in rural areas, certainly in my area in Alabama, substance use injection is a barrier to ending the HIV epidemic. This was an op-ed from Tony Fauci and Andrea Lerner before they were tied up with COVID, just describing how this is a population that's really been at very vulnerable HIV, but we have not been able to engage in really effective prevention and treatment services. So now I want to share some of our work in Alabama. Again, I know we are a very rural state, but also California does have these rural communities that may have similar barriers to care. This is a map that we have developed looking at patients who receive care at UAB Hospital. So UAB is in central Alabama, Birmingham, Alabama. It is an urban area, but we serve the entire state as a tertiary care hospital. So people will come in from a heart infection and need a new heart valve. They may have a skin and soft tissue infection that needs surgical intervention. They may be in a car accident while using substances and need very specialized care, come to UAB. And you can see the yellow is the counties where our patients come from, specifically with injection-related infections. So what you can see is that patients from across Alabama are coming to UAB with bacterial complications of injection drug use. We screen them all universally for HIV and Hep C. We need to start screening them for Hep B as well, because we know that is another infection that's on the rise in our area. But what we wanted to look at specifically in this map is when we discharge them back to their community, when they're ready to leave, where can they go for integrated substance use, harm reduction services, buprenorphine, HIV PrEP. The red dots here represent our best data from 2022 from a SAMHSA database on where people can get substance use treatment. So you can see those red dots are few and far between, and they do not necessarily not necessarily align with where the geographic need is for people who are actively injecting drugs. 2022 is before the X waiver was eliminated. So that is a policy that required people prescribing buprenorphine to go through additional training and get a certification. That was eliminated in 2022. What I've seen in my area is that that has not led to a lot of new prescribers. So the intent was that we would remove barriers for primary care docs, family docs, OBGYNs to start prescribing buprenorphine. There is literature coming out. Anecdotally, I have not seen a lot of new prescribers enter the workforce or add this to their clinical practice. So my best guess is that these red pens are likely an accurate representation in 2024 of where we can send our patients. So a little, yeah.
You said this is a rural area. How this get?
So I'm going to show you the next slide. Great question. So looking at these syndemics of substance use, HIV and Hep C specifically, we did something called a local Moran's hotspot analysis. And the areas in red are areas that have a higher burden of the specific outcome of interest than their neighboring communities. So red means higher burden. Blue means they have less burden of that specific outcome than neighboring communities. And what you can see on the far left is overdose death. Now, this is specifically in Medicaid enrollees, which, as I told you, this is limited because we do not have Medicaid expansion in our state. However, we think it's a pretty accurate representation based on where we see our patients coming from. What you can see is that overdose death in Medicaid enrollees is higher in Central and North Alabama. This is pretty similar to a paper in 2012 by someone named Van Handel, who identified counties at risk for an HIV and Hep C outbreak based on injection drug use using CDC data 10 years ago. This North Alabama counties, these are the foothills of Appalachia. There is a lot of poverty, lack of insurance, lack of medical providers, and now there's a lot of opioids and injection drug use. So that's an overdose hotspot. And you can see if you move to the middle map, you see Hep C. Hepatitis C and Medicaid enrollees, there's a fair amount of overlap in these North Central Alabama counties. That also aligns with what we see. You can see Jefferson County in both maps, right at in the center in red. And then if you move to the far right, HIV and Medicaid enrollees, you can see HIV is down in the bottom. And this area aligns with the Alabama Black Belt, which is named for the fertile soil. Traditionally, there was a lot of agriculture there. There are very few medical providers, a lot of poor individuals, a lot of individuals who do not have access to HIV prevention. So we have known about that HIV geographic distribution in South Alabama. What I thought this has been helpful for in thinking about is that these North and Central counties are also at risk for HIV. The prevalence of HIV is in South Alabama, but what this helped me think about and my team is we need to be doing more in North in these foothill areas to offer more integrated harm reduction. Syringe service programs are not legal in Alabama. Those would be a great evidence-based strategy to integrate PrEP, Hep C screening treatment, syringe services. But what we can do is add things that are legal, like Narcan, increase training and education around addiction screening, treatment, et cetera, and bringing PrEP services into those areas. Because based on this data, it's just a matter of time before we see more HIV in those northern areas. Sorry about that. Okay. So the next area I wanted to discuss was models of community-based care. I'm going to share a little bit of data from my R01, which is funded by the National Institute of Mental Health. It is specifically looking at an implementation science approach to increase screening and treatment for mental health and substance use in patients with HIV. And that was really what the funding mechanism called for. What we know about Alabama is that we have great Ryan White clinics who are doing a lot of work with the best they can. I mentioned we don't have Medicaid expansion, so we are somewhat limited in infrastructure compared to other states. But what you can see here on the left is our large green stars are our Ryan White clinics in Alabama who get federal funding to treat HIV. The smaller green stars are the satellite clinics. So that satellite clinic may be one nurse practitioner who goes down to a site in a rural community one day a week. Some of these are a monthly clinic. Like Selma is one of our satellite clinics where there's a one-person show. She goes down there and she goes once a month, and maybe she has 10 patients with HIV in that community. So what we did for this R01 was we implemented a patient-reported outcome screening platform where a patient at the point of clinical care gets a tablet where they can enter or complete a survey that uses validated screening tools for depression, the PHQ-9, GAD-7 for anxiety, Audit C for alcohol use, and Assist for substance use. And at the end, they're asked if they want to participate in future research, which is another discussion, but I wanted to put that up there so you're aware. And what this allows the provider to do is that this information goes in on an iPad, and by the time the nurse practitioner is ready to go see them, or the physician, they get this information on their dashboard at their computer at the point of care. It's very helpful for me as a substance use provider. I know if Mr. Smith has been using meth. I know if he quit drinking. I know if he's severely depressed, or if compared to last visit, his depression score is much better. So it really helps me triage my care. So we went to these rural communities, asked them if they wanted to participate. All of the ones here did. And I want to show you specifically Dothan, mostly because that's where I'm from, that little green star. So that's one of our satellite clinics. And this is their staff, which is really the two women in the middle. Everyone else is my team. You can see me in the back. But you can see the two staff is an RN, and then in the bright blue is their nurse practitioner. So that's their team. So what happens is once they get the results of their patient's substance use and mental health screening, at the point of patient care, they can then say either Mr. Smith's depression is something that we can handle here. They do have case managers and social workers, or maybe Mr. Smith is actively withdrawing from opioid use disorder and needs to be referred to the local emergency department and be linked to buprenorphine, or be referred to an addiction medicine provider, psychiatrist, et cetera, based on the responses. So this may lead to referrals. Oh, I also put this picture to remind me of group therapy. A lot of our Ryan White clinics do have group therapy. They have peer support, peer navigators on site. So some of the substance use they can handle on site, some they refer out. So that was really what we looked at for our implementation study. And I want to show you a little bit about what we found. So currently we have about 4,418 responses of about 2,700 individuals. So some people have completed this more than once as part of their clinic visits. The median age is 47. The respondents are they're very aligned with our epidemic in the Deep South, mostly Black men. Interestingly, a lot of alcohol use, 22% with moderate to severe alcohol use, but a huge variation across clinics. Some clinics, more like a third, had moderate to severe alcohol use. Similarly, about 30% report current substance use, largely cannabis. Marijuana has not been legalized in Alabama yet, so this is not being prescribed by a provider in our state. But the clinic variation here, you can see some clinics as much as 27, almost 30% are using cannabis. And then you can see a breakdown ranging from stimulants, inhalants, opioids, only 2%, sedatives and hallucinogens. So broad range of substance use. A lot of comorbid mental health conditions, which is not surprising if you work with populations who use substances. 12% moderate to severe depression, huge range again. And then interestingly for us, about 40% answered the question saying they're interested in future research participation, which has been a really great opportunity for us to increase research equity, reaching out again to people in these geographic areas to offer them opportunities to participate in research. And we are currently analyzing that data, but it looks like many patients who have alcohol use and mental health symptoms like depression are interested in research. The group that was not is those that inject drugs who are MSM have been less interested in research. So interesting breakdown. I did want to talk a little bit about stigma. As part of this implementation study, we did educate the staff and clinicians on substance use. Before we wanted them to intervene on substance use, we wanted them to understand why it was important. So what I'm showing you is the components of our PowerPoint training. We created a 1-hour on-demand video that they could watch during lunch, and they got CME credits through the School of Nursing, School of Social Work, and we really wanted to emphasize training components around The importance of creating an inclusive healing environment, how stigma can cause negative health outcomes. We discussed person-first language and the use of substance use disorder, not addict or junkie, other examples. We talked about how it's important to screen for substance use and mental health conditions, how it is evidence-based. We provided education on how if we treat the underlying substance use and mental illness, people are more likely to be engaged in HIV care and experience viral load suppression. And lastly, we talked a little bit about telehealth opportunities, and just to familiarize themselves. I don't get into a lot of it today, but this is funded in 2020 and launched during the pandemic. So there was a lot going on in the context of this implementation study. We had 32 staff at this across these Ryan White clinics who completed this PowerPoint on-demand training that, as I mentioned, took about an hour. And we did a pre and post survey. Small numbers, but I wanted to show you that there was a trend towards reduction in stigma. I just included some of these questions here. This is a standardized stigma scale. Questions like injection drug use is immoral, it's just plain wrong, people who inject should be locked up, I avoid people who inject whenever possible. We saw an overall trend to less stigmatizing responses. It's hard when you look at this graph because some of this less stigmatizing responses are agree and sometimes disagree is the less stigmatizing response, but just know that in general, this 1 hour intervention did reduce stigma in this clinic population. Before I move on to my clinic, one of the things that we're working on as a clinic and amongst our entire team of researchers is ways to develop education, because we think that stigma is, at least in part, a knowledge gap. And what we learned from this experience is by reminding our staff this is a chronic disease, it's a treatable disease, it is a brain disease, just within an hour of training, helped people answer that they were more likely to want to work with and engage with people who use drugs. So I do think it's something for us to think about as scientists. Stigma is a huge barrier to HIV care. We know about HIV stigma. Now I'm showing you substance use stigma, huge opportunity for research to improve HIV outcomes. Okay. Next, I want to share a little bit about my opioid treatment clinic that we started in our large Ryan White clinic in Birmingham, Alabama, that's affiliated with UAB. We started as an OBOT, office-based opioid treatment clinic. In the last year, we've rebranded it as an OBAT. We replaced the opioid with addiction, just acknowledging that we've got great meds for opioid use disorder. A lot of our patients are in recovery, but now they're coming in with meth use disorder, alcohol use disorder, and they've all been smokers for a long time. So we're trying to expand our services. We are small but mighty. You can see myself. You can see 2 RNs here, our case manager, and in the back in green is our peer recovery coach who's got lived experience with substance use, long-term recovery, and has been arguably the most important member of my team. We started in 2019, 4 months before the pandemic. It was an interesting time. Because it is a small but mighty team, we only see people who have opioid use disorder plus other substance use disorders. I just haven't had the bandwidth to open it up to people who have only alcohol use disorder, for example. Those individuals get referred to our addiction medicine colleagues. We meet Monday mornings, and you can see we provide a range of visits from same day. Most of our patients have an in-home induction on buprenorphine, meaning we send them home with their buprenorphine and counsel them on how to start it at home. Most people don't want to hang around in the office and put something under their tongue and wait for it to dissolve. They may be uncomfortable. They most often want to start it at home. And we also provide a range of HIV services. Our clinic director felt very strongly in 2019 that we should not replace the HIV doctor. We were concerned that there would be more people that maybe didn't have a great experience with buprenorphine and would want to leave me and then be out of HIV care. So for that reason, we work in partnership with our HIV provider. I will tell you, a lot of people who were out of care for HIV are now back in care. Once we started providing buprenorphine, they came back for buprenorphine and stayed for their ART. That's been a really interesting experience. And a lot of them, this just happened last week, will actually fall out of care with their HIV, meaning their Ryan White card expired, they're out of refills, but they will keep their buprenorphine appointment. And that's when I'm able to go back to their last HIV note, go ahead and get their labs, do their STI screening, renew their ART, get them their vaccine. So it's a really great opportunity to integrate care, but I do not replace their primary HIV provider, and that was an intentional decision. Okay, so I'm going to show you some of our outcomes. This is our early analysis. We started in 2019 of November. The bright blue line is our cumulative number of patients over time. Again, this just goes to 2021. The light blue line shows that our number of new patients a month was anywhere from 0 to 4-ish. So it's not a huge volume, but it's a steady volume, and we kept a lot of people in care. This was a paper that I wanted to show just to demonstrate for our policymakers in Alabama. They haven't listened to me, but just to show that it's very safe to actually provide audio-only telehealth for substance use. Our state medical board has, over the years, proposed a lot of legislation to eliminate telehealth for substance use. But what I can show you here is that in orange are the number of telephone-only encounters I had during COVID. In gray is individuals who had televideo through Doximity or the various apps we used during the public health emergency. Most of my patients didn't have a smartphone or minutes, but they had access to a phone, whether it was their phone for audio only or their mom's phone or the shelter they were staying at, the phone. So what I wanted to demonstrate for this is that we did a great job. We kept people in care. I think this is a great model for future pandemics, but also people that have lives that are so chaotic that they might as well be living in a pandemic. They're living under bridges. They're living couch surfing from aunt's house to friend's house, for example. And this is our care continuum at the same time. So this is looking at the overall group in blue, those with opioid use plus stimulant use disorder in orange. This is about 30% of my clinic currently, has varied over time, but a lot of patients have opioid use disorder and stimulant use disorder, primarily meth in my clinic. So those are in orange. And then in green is opioid use disorder alone. Small numbers here. Did I show? I think the overall number was, sorry, y'all, I was just trying to remember how many total patients were included in this. I want to say it's like 50, 57, 58. But what you can see is similar trends, and overall about 78% had viral load suppression when we did this analysis in 2021. So pretty good numbers for people with opioid use disorder. Still have work to do, still don't have great pharmacotherapy for stimulant use disorder. So a lot of patients who are in recovery from their opioid use disorder, but they're still using meth, some are using cocaine, and still coming in with STIs and other complications from the vulnerable risk behaviors, intersections in this population. This is one of our community outreach efforts to integrate services. So I showed you what we're doing at our Ryan White Clinic. This is a SAMHSA grant. I was talking to somebody before this about SAMHSA, CDC. SAMHSA has been a great way for us to provide services in the community. They are not like the rigorous NIH grants, but they do allow you to collect some data, and they provide a lot of great services. So what you can see here is a SAMHSA Prevention Navigator grant that I also got around 2020. This is an EHE, Ending HIV Epidemic initiative, a 5-year initiative I did with the Addiction Prevention Coalition, which is one of our nonprofit partners, and our Community Advisory Board, our CAB, has been really helpful in helping identify people at risk for HIV and substance use. So in our area, that's been youth, that has been young people. So we have done community pop-up resource fairs in areas where we know young people are going. We've worked with schools. We've worked with our adolescent medicine clinic, who also works with juvenile detention centers and drug court involved youth. And the main intervention is a prevention navigator. You can see her in the bright blue shirt. Her name is Ashley. She works at the Addiction Prevention Coalition. She does motivational interviewing. She does counseling. She has a counseling background when she goes into these spaces and meets with youth. And we've also been able to integrate HIV and Hep C testing, naloxone. Only once it was over the counter. I put the OTC here just to remind me to tell you all that it wasn't until 2022 that lay people could distribute naloxone in Alabama. Our pharmacy board had previously restricted it such that only an MD or a nurse practitioner could give naloxone out in the community until it became over the counter, which was a huge barrier to community outreach, but now it is over the counter. And then PrEP referrals is another thing we do. So at the top, you can see us, my team and students putting together these harm reduction kits. They have wound care supplies because we do have a fair amount of wounds in our community who uses, especially the unhoused community, Narcan, do not use alone and other hotlines for them. I'm sure I'm forgetting something, but been great at socks, hand sanitizer, some hygiene products. And then at the bottom, I wanted to show you is one of the parks where a lot of our unhoused population, this is this is George Ward Park. And it looks lovely from the photos, but what one of my colleagues took a photo of was all the syringes that are just, you know, littered across the space. So another thing we have started integrating is empty laundry detergent and other milk jugs for people to use for their safe disposal of their syringes. We do not have legal syringe service programs in Alabama, and we obviously have a problem with discarding disposed syringes. So this has been a 5-year SAMHSA grant. We're entering year 5. Just a little bit about this group. So you can see we've engaged mostly Black, 56% Black, young. You can see at the bottom, about 70% are 14 to 18. The study really only went up to age 23. So it's a young group. A lot of them gender and sexual minority groups, a few trans individuals. And what you can see on the right is the counseling and motivational interviewing did slightly improve over time. Self-reported alcohol use, self-reported marijuana use, and self-reported vaping over time in this at-risk group. Again, it's a service grant, so there's not a lot of rigorous analysis, but we did want to look at this just to see how we're doing with our counseling. And I think the bigger thing we've provided is really some of these services that are harder to quantify. The thing I'm most proud of is that when fentanyl test strips were legalized in Alabama, which just happened 2 years ago, because we had this partnership, because our community advisory board was intact and helping us identify needs in the community, we were able to rapidly purchase fentanyl test strips legally and get them out as part of these pop-up fairs. So we disseminated over 7,000 in the first year. And here's an example of one of our faith-based partners at the Winona AME Church, where you can see we did a pop-up research fair. We had people from the health department. We had HIV testing. We had housing partners there. A really great opportunity to integrate these services. We don't have a mobile unit. I know that there are lots of people who are working in that space. It is something that I'm hoping to get. We've just had bandwidth issues in doing all the work in our kind of resource limited environment, but that is the ideal. That's the goal, is to have an integrated mobile unit to reach this population. Integration really reduces stigma. And some of you may have heard this notion of no wrong door. It's been used in the mental health space to really remind people that people who are having a mental health crisis should be able to go to their family medicine doctor or their ER doctor or any number of community health workers and get access to care. Meaning we all provide this service. There is no wrong door. And I think by integrating these services, we've shown our community there's no wrong door. You can come to this community health fair and we can provide any number of counseling and education. The health department's there, but you can also get HIV screening, right? So we're integrating these. They're not viewing it, oh, that's only for addicts and junkies. I'm not going to that event. Or, oh, that's only for people with HIV. I'm not going to that event. By integrating, we normalize substance use as a chronic disease, HIV as a chronic disease, and we increase opportunities for our patients to get access. Okay, so we're doing great on time. This is the last kind of objective. I know we talked a little bit about some hospital-based initiatives, and I just wanted to share what we're doing for patients who are acutely ill. This is a multi-site choice study that we did in 2020, looking at University of Maryland, UAB, GW, and Emory's patients who inject drugs with bacterial complications. This term, serious injection-related infection. And again, that refers to bacterial complications, heart infections, skin and soft tissue, bloodstream. And we had across the 4 sites from 2018 to 2019, we had about 287 individuals from the 4 sites. You can see on the right, this group was 59% male. That has now moved in Alabama, at least, to more 50-50. Many women are involved or experiencing this outcome. A fair number were uninsured, 25%, and about 36% had unstable housing. Another 17%, there was no documentation of housing. And 71% of these people were not on medications for opioid use disorder. So that has not really changed since 2018. This is the breakdown of the skin and soft tissue infections that people were coming into the hospital with in 2018. You can see a lot of skin and soft tissue. You can see a fair number of bacteremia, endocarditis, a range of other infectious complications. But what I just want to remind you is that those are just the tip of the iceberg. If we look, we'll find a lot of other infections in this population, whether it's hepatitis C, STIs, we see a fair amount of that. Even we know that the SARS-CoV-2 pandemic was disproportionately burdened our groups who were unhoused, used substances with mental illness. This is an important reminder just of the touch points and the opportunities we have with this population. This is again that choice study, and the green arrow, which is a little small here, shows when we there's a retrospective study. That was our sentinel admission, was the green arrow. You can see prior to that, in looking back through their charts, 37% had been to the hospital in the year prior. So this is a group that's in and out of our ERs, in and out of our hospital. A lot of opportunities to do good evidence-based care. You can see that 78% had a planned discharge. That means that the other 22% left prematurely. We used to say AMA, against medical advice. That is a stigmatizing term. So we now say prematurely. And then another 50% had an ER visit readmission within the next year. And if you're a clinician in this group, you know that's very common. Here we found that 5% were dead within a year. I can say at UAB more recently, it's more like 10% with fentanyl, because 2018, we weren't seeing as much fentanyl. Now, when we look at this population, we're seeing more like 10% are dead within a year. And these are like 30-year-olds. These are young people with young families. We also looked at the PrEP cascade. I don't love this slide, but I just had a hard time coming up with a better way to visualize it. Of 287 across these 4 hospitals, 22 had HIV on screening. Of those, 19 were a known diagnosis. 3 were a new diagnosis. So 3 out of 287. Only 7 were on ART. Of those 19 who were known to have HIV, only 7 were on ART. And we only found 1 that was HIV negative who was discharged on PrEP. So a huge missed opportunity for counseling and linkage to HIV prevention in this population. Again, that was all 4 sites. Oops. All right. This is a project that I've done with a medical student that she just presented at ID Week. But we did a survey. This is a great study for trainees to get really involved and get to know a population. She did a survey of sexual risk behaviors and drug of choice in patients receiving care at UAB. She had about 60 participants and asked a whole battery of questions. There's a standardized survey called the BRAID, BRAID, which asks about a lot of sexual and substance use related HIV and infection risk. And I'm just showing you a small snapshot, but you can see 30% had unprotected sex while they were high on a stimulant. More like 50%, N equals 30, 31. So over 50% had unprotected sex with someone who uses drugs, so their partner, and over 50% shared an injection needle. I imagine it's even higher than that because, again, we do not have access to sterile syringe programs in Alabama. So really important work and really enlightening, I think, for our ID division to share this with them so they're appreciating the risk in our patients who, again, we view them as bacterial infection and we always silo our risk behaviors, but people don't always think of this as an opportunity to link people to HIV prevention. This is some qualitative work that we did with our addiction medicine group. This is, again, a very small study, but this was a pilot study looking at why are physicians not prescribing PrEP in this population? And you can see we had about 9 participants. 67% were general internists and 33% were ID docs, a range of years out of practice, since training. And just a few quotes that I thought were interesting. I was shocked that one didn't even realize that PrEP could be used for IV drug users. And then another person, clearly like an HIV researcher, who's talking about intersectional stigma as part of his interview, his or her, comments, there's homelessness, that may be a piece to their story, incarceration, all these sorts of things may play into the person's whole picture. And I think this just summarizes a lot of our challenges as clinicians. Our patients don't have a home. They don't know where their next meal is going to be coming from. They have, a huge wound on their leg. Thinking about HIV prevention often falls very low on our list of priorities and on the patients, frankly. We're seeing that as we're starting to offer it, not everybody really is ready to take on a preventive medication, but a lot of barriers, and we do need to chip away through education on the patient end, but also providers. So lastly, I want to talk about some of the things we're doing in our hospital. You all may recognize this map. This is the NIDA Clinical Trial Network sites. So this is a network that UAB is actually not a site for, but we were selected for this hospitalized study called the SERIES study. It is the Integrated Care and Treatment for Severe Infectious Diseases and Substance Use Amongst Hospitalized Patients study, also known as 0121. So what the intervention is here, and this study is recruiting currently at UAB and 6 other areas across the US. It is an integrated ID addiction doc. It's basically an LN going around with frequent touch points while they're admitted. And then we have a nurse champion who's doing telehealth. We have an outreach worker. We've been able to have really great retention because our outreach workers are just lovely people, and our patients answer the phone and answer their texts. And when they miss the phone call or we reach their emergency contact, our patients have just stayed engaged in a really pleasantly surprising way, because we have staff that is not stigmatizing and that's really using compassionate care to keep them engaged. So this is our team here. We're at about 44 enrollees. We got one today. And it's been really, it's not rocket science. It's not a super innovative intervention. It's very common sense. It's based on work by David Sirota, who's an ID doc at Miami. And he has shown that by doing this type of very intensive touch point in the hospital and then less intensive, but still continuity in the community, has reduced readmission and death, which are the primary outcomes. We're going to close just by talking about some other infections, specifically Hep C. Just a reminder for the group, hepatitis C screening and treatment has not traditionally been provided to people who are actively using, but the IDSA and the American Association for the Study of Liver Diseases actually says those are the people that we need to be screening and treating. If you're thinking like an epidemiologist or from an infectious disease model, a public health model, the people who are actively using, they're maybe injecting, they're maybe exchanging sex for drugs or money or housing, survival sex. Those are the people we need to be eradicating in hepatitis C in them, because they are the ones who are actively transmitting. So now real strong guidance. We need to be offering harm reduction. We need to be screening them and linking them to hepatitis C treatment, which we now know is curative for many people. So a lot of these things can and should be done meeting people where they are. For me, in a state where we don't have Medicaid expansion, we have very poor public health infrastructure in the communities. A lot of patients, as I showed you at the very beginning, come in and out of my hospital and my ER often. They are often there. And what we've seen, they were here in 2018 with Hep C, and they came back in 2020 to deliver their first baby, and they still have active Hep C. And then they were in a motor vehicle accident in 2024, and they still have Hep C. So we know they're not getting these services in the community. So what we have a pilot for now is, we've always done universal screening for 10 years, Hep C screening, but we have not used the hospital as a linkage point. So we're now working with a nurse champion. This can absolutely be done by an outreach worker. A nurse champion does not have to be an MD, to go ahead and run their insurance if they have it. If not, reach out for copay cards, pharmaceutical compassionate care programs, get hepatitis C medications arranged so they can pick it up on the pharmacy on their way out or sent to their home address, and doing a telehealth to check in. Ideally referring them for labs in their community, but that should not be a barrier. We know that people who even have some non-adherence, don't complete their course, are very likely to experience cure, and requiring that they go to LabCorp or some other commercial lab that they may not have insurance to cover is just one more barrier. So we are doing the best to get them treatment, telehealth, encourage follow-up with an FQHC for labs, low barrier clinic for follow-up labs, but we have not made that a requirement for treatment. This has been done elsewhere. There's great work. I'm including some references here. UNC has done this. Pittsburgh has done this. A lot of people starting to use this hospital touch point to really work on Hep C in their communities. Audrey Lloyd is one of our early career faculty who's been a champion for this, and then our nurse champion who's been tremendous in helping us get this off the ground. So that's really it. In conclusion, I wanted to remind you that substance use endemics are on the rise, and they're creating a lot of opportunities for us to integrate care. Care integration can reduce stigma, again, by normalizing screening and treatment. And then lastly, we really have to identify new non-traditional touch points. I mentioned the hospital, I mentioned community health workers, I mentioned pop-up resource fairs to improve health equity in persons who use drugs. So that is really my talk. I wanted to share a couple resources with you. This is This American Life from a year ago called The Call. It is, I think, 45 minutes. It was released in conjunction with, I think September is National End Overdose Awareness Month. And it spotlights this Never Use Alone free resource that is a hotline and really gives the testimonials of people who called. And there is a lovely person like this woman featured here, I think her name's Melissa, who makes sure that they are still breathing and can respond either to the audio or via text, such that if they overdose, she knows how to send EMS to their house. So they have instructions, leave your door open, et cetera, et cetera. And the amount of lives she has saved and changed is really, it's a great introduction to harm reduction in action. And then the next resource, this was actually an NPR piece that myself and my peer were interviewed with. The Gulf States Newsroom is one of the kind of regional NPR newsrooms. And this journalist wanted to think about opioid settlement funds and how they are or are not, spoiler alert, are not addressing the opioid epidemic in Alabama. And so this journalist went with our peer worker under bridges and to encampments and asked really hard questions. And it's really interesting just to hear the stories of the people affected by this, including wounds, including infectious diseases. So I wanted to share that for those that are interested. And then my team. So I think we have a few minutes for questions if there are any. And thank you for this opportunity, for being such a captive audience. Very grateful to be here.
I would love to hear about your OVAT clinic and your patients. It sounds like you are the main addiction person, and then you said that there are other clinicians who provide HIV care. Do you feel like the patients have more interactions with you during telehealth and not, versus their HIV clinician, where they require them to come in, they're coming into the labs, and how do you sort of navigate the lab piece of that, their need for additional testing for their HIV, to make sure practice, to make sure that they're not.
Yeah, this is something we've really struggled with, is how to use telehealth now that the public health emergency is over. We're in a different stage of COVID. I will say that because so many of our patients have other needs, social needs that are met physically in the clinic, food support, our pharmacy is on site, labs. We encourage everybody to come in person. Last week, I think I did 2 audio only encounters for people who, it's very common that they're in recovery and they have a new job, and their new job doesn't want them leaving every month for their check-in. And so that's a tension that we have, where I'll start doing telehealth during their lunch break, right? That's an example of how I'm using telehealth now. There are some people who, due to young kids or other demands, most of their visits are over the phone. But as I mentioned, my state medical board requires that I bring people in more often than the DEA, and probably than your state does. So there are also some policy reasons that I'm bringing them in. As this question of, do they engage better over the phone? There are some people that the stigma of coming to the clinic is still a huge barrier. And it's people that have even been in our clinic for a while, and they would much rather just talk to me on the phone, just their voice. And we ran into some ethical concerns during the pandemic. What do we do if they are, actively using, or there's are they going to feel uncomfortable under the bridge, or, with drug paraphernalia in the back? We did run into some concerns where we felt like, maybe that's just to let them do audio only. So I think the vast majority now are coming in person. their HIV visits, they're almost all coming in person. I am an outlier, and I know that because my hospital billing reached out to me about that I am an outlier in how many telehealth encounters. Obviously, there's not parity in reimbursement. So the bean counters do not want me doing telehealth. I think there's a group that will always engage better over the phone only. And in my clinic, their regular medical encounters are not happening with a telehealth option anymore. So, but the reason I showed that slide and the reason I wrote that paper is to say, hey, we can do a lot of good care and keep people engaged with these options. I think it remains to be seen how payers do or don't allow telehealth going forward. Yeah.
Good question. What are the biggest source of public? Is there anything on business?
That is a great question. I am not an expert in the drug trade. I do not know where most of their supply is coming from. I know that it is very easy to get fentanyl. I know that a lot of our patients who are in the hospital for a bacterial complication, for example, can go to the bus stop and get fentanyl, meth, and be back in their room before the nurse even notices they're gone. And I will say that our supply is very adult. I mean, we have xylazine. I was talking with someone earlier about all the contaminants that our forensic pathologists are finding in the drug supply. So it is a very dangerous, unregulated supply. I don't know exactly where it's coming from. Yeah.
I was wondering if there's any challenges with the technological literacy, especially in rural areas with probably technological needs. That it's being used to its fullest potential and if it's a sustainable sort of program and how it can be.
It's a great question. We actually have published on that, and I'm happy to share some of those. We did some qualitative interviews and some surveys. So we know that even in these rural areas, most people have a smartphone, and many of them also have a tablet. We've asked some technology, we've asked technology literacy questions. I will say there were some people, particularly older people, that had trouble with the devices because it is done on the clinic property. There is a staff there who can help them if they need it. And those staff have also been helpful. We have a lot of people who can't read. I shouldn't say a lot. It is not uncommon for a clinic to tell us that their patients cannot read. And they can tell you who those patients are because they have trouble with their Ryan White forms and they have trouble at the pharmacy. So the clinics in these areas know who can't read and they will have to read the questions off to their participants. And then between technology, reading, and then the other small barrier, there are some communities that have patients that speak English as a second language. And we have translated this for one clinic to Spanish, but only one clinic had reported patients needing the validated tools translated to Spanish. So those are the main barriers, but I will say as a general rule, most people, as you can see, like 4,400 responses has been easier than we anticipated. Great question.
Zoom question? Is that okay?
Oh, yeah. I see the hand. Yeah.
Yeah. As someone who has lived experience of substance use disorder, HIV, mental health issues, and homelessness, I applaud the integration of at least the substance use and HIV part of that. I just want to stress and bring up, because even in your presentation, you spoke often of people who were either housing insecure or were homeless, and the importance of linkages for housing or for other services. None of those other issues were able to be addressed until I became housed.
Yeah, I think it's a great reminder. And I'll be honest, there are some clinics where it seems like half of my Monday patient panel walked to my clinic from the 3rd Avenue overpass encampment. Really, those patients, I just commend them for even making it, right? Having to walk just to get your medicine after, we have numerous police sweeps. We have so many barriers to care, but I agree the housing first model, there's great literature to support that. That is really where we all need to be going. I have a lot of work to do. Anybody here, we're hiring at UAB. We're hiring at UAB. I've got a lot of work to do, but thank you for bringing that up and for joining and sharing your perspective. I think housing first, along with medication first, are really the models we should be looking to.
Thank you.
Thank you for that amazing talk, the work you're doing in the face of tremendous adversity from a socio-political standpoint in Alabama is really, really impressive. Could you talk a little bit about how some of the legislation that has evolved in Alabama has impacted your ability to do this work, both from a research standpoint and from a care and program delivery standpoint?
Yeah, there's a lot of opportunity, missed opportunities and a lot of examples. I would say, I've had to really toe the line, and I've, been very vocal. I gave the example about my state medical board. In 2022, the DEA said no more X waiver. This is a barrier. If we require physicians to do this additional certification to prescribe buprenorphine, we will continue to see low prescribing rates and patients without access to meds. My state, in response, my state medical board drafted a 46-page PDF of additional requirements on me now that the X waiver is gone, on me and other prescribers. And we had to create letters. And as a state-funded institution, that was not popular with our leadership. But we as physicians had to say, our clinic cannot exist if this policy is passed. So that's one example of, we try not to say the word advocacy. I think we're supposed to say engagement. We had to really engage with our institution's government liaison, counsel, the attorneys there, and talk about the appropriate channels to send our letter to. And truly, it wasn't until we got some media attention that our state medical board totally dropped that bill, and it has not come up since 2022. So that's an example. I mean, that took some risks. I was not yet tenured. That did take some risk, but it was obviously something that I knew if that bill had passed, my clinic would cease to exist. There's so many examples. The opioid settlement funds have been very political. I don't know where the opioid settlement funds in California are going. In Alabama, they're going to a general fund with a committee of mostly lay leaders from across the state who have no medical, public health, or addiction background. And there's no very much limited reporting on them. There's no transparency in how they're selected. We anticipate that a lot of those funds will go to faith-based, non-evidence-based detox programs, et cetera. They will not be invested in building new clinics or evidence-based models of care. So that has been another opportunity for me and other physicians and scientists to go to our leadership, to talk to our government liaison, our council about how to advocate for that. That has not paid off for us, but lots of examples. I will say this issue is more bipartisan than a lot of the issues we're dealing with in Alabama. Our attorney general, his first wife died from an opioid overdose, but even when they're personally affected, that doesn't mean that they advocate for and vote for evidence-based things like syringe service programs. Which we still don't have. So I don't know if that answers your question. Those are just a few of the examples of challenges in this socio-political climate. Yeah, question.
Maybe this is like a really nice, but why is it?
It is it's thought to, and much like some groups do not want sex ed in schools, including my state. There's very progressive education, sex ed, and certainly would not support condoms being distributed. It's thought that it would enable, sexual activity. Similarly, it's thought by some groups, and is not evidence-based, but is thought by some groups that providing syringe services will cause people to start injecting drugs. Rather than the harm reduction and the evidence base. We know as HIV docs, infectious disease docs, which is that when there was an HIV outbreak in Scott County, Indiana, many years ago, opening syringe service programs is how they stopped transmission of HIV and ended those clusters and outbreaks was by providing sterile syringes. So it's a CDC best practice, but I've been told by leaders who have tried to get those approved in my state that after COVID, the public health officers and leaders in my state lost so much political capital by advocating for things like vaccines and masks. They don't feel like they can effectively advocate for syringe service programs in the political climate that I'm in. Does that answer your question? So.
We're just at the top of the hour. Thank you so much. I mean,
Thank you.
it's an incredible talk. And I will say, you know,